Price.
Thank you, my lady. Professor Smith, I'd like to deal next, please, with some specific PPE challenges and the response to those, starting with the impact of supply constraints. You refer in your statement at paragraph 167 to there being widespread concern, expressed informally and formally, that measures being recommended were insufficient, based in part on a concern that this was being driven by supply constraints rather than science. Dealing first, please, with what those supply constraints were in Scotland, there were 3 related submissions to the Cabinet Secretary for Health and Sport and on stock and supply issues with FFP3 masks, and the use of time-expired FFP3 masks and those submissions are March 2020. Do you know the submissions I'm referring to?
I do, yeah.
They were all copied to you. Have you had a chance to review those recently?
I have, yeah.
You were at the time Deputy Chief Medical Officer, is that right?
That's right.
Could we have on screen, please, the last of these submissions, dated the 24th of March 2020, please? It is on the screen. Going to page 2, please. Is it right to summarise the background to this submission in this way? The Scottish supply of FFP3 masks was critical, and that was the word used in one of the previous submissions. Efforts had been made to obtain more stock, but this was proving difficult because of international supply delays. Minister's approval had been sought to pre-position time-expired stock of FFP3 masks following UK-wide stock validation testing, which had been arranged by Public Health England, and that approval had been given. Is that a fair summary?
That's my recollection of events at that time, yes.
This submission sought ministerial approval to use the time-expired stock, which had passed quality assurance tests. Is that right?
Again, that's my recollection, yeah.
Paragraph 4 set out the position which had been reached. My submission of 21st of March noted the fragile position in relation to current FFP3 stock and in relation to new supplies. National stockpiles now hold only 16,000 after distribution to boards of 73,000 last week. We have retained around 1.5 million FFP3 masks made by 3M, which had recently gone out of date after previous shelf life extension, from a total of 19 million held across the 4 nations. We are now moving to a position where we need to consider using this stock. What steps did you take at this stage, if any, to ascertain whether health boards were still experiencing shortages in supply of FFP3 masks? There was a reference in the earlier submission to reports of a shortage in supply.
So personally, I didn't take any steps because, again, this responsibility lay with a particular team within Scottish Government, a particular directorate that had been formed, looking at the subject of PPE and the supply chains that were related to that. And as one of the health and social care directors, we received reports back from that team during the discussions that we had in relation to the position. So I was certainly aware of the difficulties from that perspective, but this wasn't an area that I was particularly involved in or active in at that stage.
So you were being copied into this submission, not because it was your responsibility, but to keep you informed?
This was about information rather than anything else.
Over the page, please, at paragraph 13. Deployment of the stock. The priority is, of course, to secure deliveries of new stock and to deploy that or other in-date stock to any which is not technically in-date. However, it will also be important to deploy the respirators in a way which maximises their usefulness. Therefore, it is likely we would wish to deploy them immediately, and that they will continue to be issued concurrently with any new stock which becomes available in order to reduce fit testing burdens on boards and staff. We then have fit testing dealt with at paragraph 14 below. If approved to release the 3M FFP3 stock, additional assurance on safety in using these masks will be provided through the use of the port account machines used to fit test the masks to staff. These machines are already being deployed across boards. These will greatly speed up fit testing, reduce burdens on boards, and have been improving fit test pass rates to help ensure safe usage in practice. Such results will help improve staff confidence in their own safety. Is it right that approval was given for the time-expired stock to be released to health boards for use?
Again, that's my understanding.
At this time, did you have any concerns about the use of time-expired FFP3 stock?
Given that they had been through a quality assurance process and had been passed by the Health and Safety Executive, no, it didn't have expressed any concerns.
Were any concerns raised with you about this at this time?
No.
Were the port account machines provided to health boards to assist with fit testing as had been planned? Do you know?
I wouldn't be aware of that information.
Could we have on screen, please, INQ 304781114? This is Professor Mackay's statement, which we looked at earlier, provided on behalf of the Glasgow Royal Infirmary. Could we go to paragraph 124? That's already on screen. Professor Mackay says this about the Glasgow Royal Infirmary's experience. By the second week of March 2020, we had used the bulk of our FFP3 supply to complete the fit testing of our staff. We then received a supply of FFP3 masks from the national stock, which proved difficult to fit, the initial failure rate being 75%. Fit testing is mask specific, so the national stock being different to that which we had originally tested our staff to meant that the fit testing exercise had to be repeated. This was a surprise to us and proved time-consuming. A further batch of different FFP3 masks was delivered, which had a failure rate of 45%. These dated from 2012, and although they had been revalidated for clinical use, there were concerns that the elastic had lost its resilience. There was evidence that some of the straps snapped when donning these masks. These cannot be tightened as fixed straps. Were you aware at the time that Glasgow Royal Infirmary had these problems with fit testing and that there were concerns about the straps on time-expired stock?
No, I wasn't.
Were you aware of wider concerns about time-expired stock falling apart? The filtration device might work, but the parts holding an FFP3 together had denatured. That was evidence that the inquiry heard recently. Were you aware of that at the time?
I'm afraid I wasn't, no.
Did you or your team ever follow up on what the impact of using time-expired stock was on healthcare workers?
Again, that wouldn't have been the remit of my team to follow that information up. That would have been the specific team set up to deal with PPE. And I'm not aware of any of my team being involved in any follow-up.
That document can come down now, thank you. Had these concerns come to you in your role as CMO, or Deputy CMO as you might have been at the time, do you not think there might have been a responsibility to look into the issues, given that they were experiences on the ground of clinical practitioners?
So if these issues had been raised directly with me and not through other sources, then yes, I would have taken those issues to the responsible team to look into further.
I see. So you would have responded had they been raised to you, but following up on the stock issue and the experience would not have been your role. Is that the distinction you draw?
Yeah.
Okay. The last COVID-19 IPC guidance consideration you listed at paragraph 145 of your Module 3 statement was the impact of the guidance on workforce morale, with the aim being to support and reassure clinicians. Some insight into the question of whether clinicians felt supported and reassured was provided by the BMA PPE survey, the results of which were available in April 2020. Could we have on screen, please, INQ 30117-023. This is an email from Jill Vickerman to you, dated the 7th of April 2020. I think that's the day after you took up the interim CMO role, is that right?
It would be, yes.
She is flagging up the results of the UK-wide survey, and it appears from this that a call was to be set up with you to discuss the Scottish figures. Is that right?
I have to say I don't recall any such call being set up. At that point in time, it may have happened, but I have no recollection of that period, the specifics of any call. I know that there were certainly liaison with Jill and other members of the BMA at that point in time, in regular meetings with either members of my team, myself, or very often with healthcare workforce who were responsible for the relationship with the BMA.
Did you come to have an understanding of what the Scottish figures specifically showed?
I am not aware of that understanding, no.
Okay. Can you help with whether the Scottish figures broadly reflect the UK-wide picture?
Not at this time, no.
The email which was forwarded to you by Jill Vickerman summarised the UK-wide results. At the bottom of the first page is the result that more than 2/3 of doctors have told the British Medical Association in a new survey that they do not feel safely protected from coronavirus infection where they work. Going to page 2 of the document, paragraph 3, according to the survey, more than half of doctors working in high-risk environments said there were either shortages or no supply at all of adequate face masks, while 65% said they did not have access to eye protection. Alarmingly, 55% said they felt pressurised to work in a high-risk area, despite not having adequate PPE. The next paragraph records that 90%, almost 90% of GPs in contact with COVID patients reported either shortages or no access at all to eye protection, and 62% reported problems with supply of face masks. More than half of GPs who responded said they felt they had had to buy their own face masks or eye protection, with only 2% saying they had felt fully protected against the virus at work. So this survey was suggesting that doctors felt that they did not have access to the PPE, which was being recommended. Looking at the paragraph below, we can see here the survey shows the doctors are not being provided with the appropriate protective equipment as specified by the government's own guidelines. So this wasn't a disagreement with the IPC guidance. It was there wasn't enough PPE to comply with the guidance. What did you do to address the concerns about PPE, which were being raised by the BMA on behalf of its members in April 2020?
So at that point in time, there was significant pressure, I remember, on many of the supplies in relation to PPE. And my recollection, and this is a recollection, again, I would emphasise that I wasn't directly involved in the provision of PPE. So this is my recollection from discussion in directors' meetings, was that the PPE directorate were establishing those supply lines and had successfully been able to enable central supplies of PPE within Scotland and retain those central supplies. Some of the difficulties that we became aware of was in the not in the central part of the supply chain, but actually at the very ends of the supply chain, and ensuring that within some of the units that were using PPE, that there was problems actually getting them in sufficient numbers to the people who were delivering the care. Subsequent to that, this was an area that after this discussion, our Cabinet Secretary at the time, Jean Freeman, took quite a significant interest in, and set up a helpline that any worker who was concerned about the supply of PPE, or the availability rather of PPE in the units that they worked, they could phone this central number to express their concerns, and so that those could try to be addressed as quickly as possible. I'm certainly not aware of any direct contact that I or members of my team had in relation to that. And I am aware, again through discussion in particular forums and with the Cabinet Secretary at the time, that the helpline appeared to be working well in terms of being able to address some of the concerns.
That document can come down now, thank you. You have been directed by the inquiry to a number of paragraphs from Dr. Barry Jones's statement to the inquiry, as well as the statement of Ms. Gillian Higgins. The paragraphs to which you have been referred refer to 2 meetings which you are said to have attended with Ms. Higgins, the first being on the 21st of April 2020, and the second being on the 13th of April 2022. Do you recall meeting with Ms. Higgins now?
I recall parts of the meetings in both cases. The first meeting, I rather more recall the general demeanour of the meeting and rather than the specifics.
What was the general demeanour of the meeting?
Generally constructive, positive, listening. It was a meeting that a chance really to listen to the concerns that were expressed.
Could we have on screen, please, paragraph 57 of Ms. Higgins' statement? It is page 16 of INQ 30421873. This paragraph is referring to the 21st of April 2020 meeting, the first of the 2. And it says this: I also specifically recall that the CMO stated that while protecting staff was important, the government did not wish to overreact by implementing measures of a higher standard than we needed and that couldn't be sustained. My colleague contributed that he did not agree that protecting the workforce, in particular vulnerable members of our community with higher risk of death from COVID-19, with evidence-based solutions was an overreaction. I also reiterated that high-quality RPE is readily available, would be more cost-effective, and would lead to less nosocomial infection, staff illness, and death. Do you recall expressing this view or a similar one at the meeting, that the government did not wish to overreact by implementing measures of a higher standard than were needed that couldn't be sustained?
So I wouldn't be able to tell you the exact language that I used, but I do remember speaking about the need to make sure that the response was proportionate, proportionate to the risk that had been identified through the various groups that were examining this, and that in responding in a way which was disproportionate, it might actually lead to more concern if those items which were being specified were not sustainable, and there you would be in the really kind of difficult position where an over-specification had been made higher than was thought to be necessary by the expert groups, but wasn't sustainable and would create unnecessary worry in the minds of staff. Very difficult to retreat from a position of higher specification to lower specification, whether it was necessary or not, and particularly if it was unnecessary, felt unnecessary by these groups, and that was certainly a concern.
That document can come down now, thank you. Do you recall the potential for reusable respirators being discussed in the two meetings with Ms Higgins?
I recall that perhaps more from the second meeting in 2022.
Of which there are some minutes, which I think you've seen.
I don't think those were minutes, but those were...
A note of the meeting.
A note of the meeting, and perhaps involved a Teams chat associated with the meeting.
And what do you recall from discussions about the potential for reusable respirators?
So I remember the evidence that was presented at the meeting, the discussion that followed, and I remember it was quite a difficult meeting. I think it was at a time when there were some very difficult conversations which took place during the meeting, and one of my, I guess, one of my regrets of that meeting in particular is that I probably didn't take my best self into that meeting as well, because of other stresses on the day. That said, one of the things I was unhappy about over the course of the meeting was what appeared to be members who had come to speak advocating for a particular company to be approached. It's something that I find quite difficult in the role, is that commercial contacts, I don't think, are part of this role. And I need to keep my independent advice. And particularly in relation to this meeting, it felt as though we had things the wrong way round. And rather than specifying a level of product or approach which we all agreed was necessary, and then going out to an open procurement process to identify who was best placed to be able to supply that with best value, what was being advocated was a particular company who should be approached in order to look at this. And that seemed to me the wrong way round, and I was concerned at where the conversation was going.
Did you have any involvement in decision making in relation to the use of reusable respirators?
No, I didn't.
Moving please to shielding and the highest risk list. You explain at paragraph 203 of your Module 3 statement that the 4 UK CMOs jointly identified certain health conditions which could, based on risk from respiratory illnesses like flu, mean someone was potentially at higher risk of negative outcomes if they contracted COVID-19. Is it right that there was no divergence across the UK in respect of this identification?
At that point in time, yes, there was no divergence. Perhaps the only slight divergence that there wasn't in the 6 groups that were identified, but in Scotland we also gave, I think, a greater degree of flexibility at the outset for clinicians to identify additional people that they thought was beneficial to add to the list.
And just in terms of the date of that, is it right that it was the 18th of March 2020 that the agreement of the CMOs was reached as to which groups should be on the list?
That would be consistent with my recollection of data during that period. I remember that Dr. Calderwood was still CMO at that point in time, but I also remember being involved in some of the conversations myself.
Given that you were DCMO at the time, to what extent were you involved in that agreement process of the UK CMOs? It
was primarily led by the 4 UK CMOs, but with input from DCMOs on specific items.
And what was your view at the time on the approach and the conclusions reached by the UK CMOs?
So in the absence of other evidence at that stage, then it acted as a good starting point from which we could begin to build further information, particularly, as I say, in Scotland. I felt that it was important to have an additional layer of flexibility for clinicians to identify people.
Do you think that support for those shielding was adequately built into the initial design of the shielding programme?
I think this was an incredibly difficult thing for anyone to even contemplate, what was being asked of people who were asked to shield. And you know, when you look back on that time and what people who eventually went onto that shielded list were asked to do and asked to sacrifice in particular, I think it's such a difficult undertaking. The supports that were built in round about it were placed as best as they can to try to support people. But I think inevitably for anyone who is essentially cutting themselves off from society and is surrounded by fear because we've said to them, you're at a higher risk, inevitably there's additional things I think that we could have done. And I often wonder whether having some sort of inbuilt mechanism for greater mental health support during that period would have been of an additional benefit for them.
Do you think that would be of additional benefit if such a situation were to arise in the future?
I sincerely hope that we never have to revisit a situation like shielding, but certainly if there was evidence that it was beneficial, then one of the things I would certainly want to do would be to make sure that we had a much greater degree of mental health support for people who are put in that position.
Do you recall discussions about the dividing line between the clinically vulnerable and the clinically extremely vulnerable?
I don't actually.
Do you think you weren't involved in those discussions?
I'm not sure that I was involved in those particular discussions, but I'm happy to say from my view and my perspective is that I think that those were often discussions which were really difficult to judge as to where a line could or should be drawn, given the evidence that was available. And it was very much about using as much clinical judgment in that space. I guess we should remember that it wasn't just the 4 UK CMOs that drew up these groups and that they in turn received advice, not just from the DCMOs who were involved in some of the discussions, but also from other clinical groups as well during that time, and that this tried to create as judged consensus as possible as to how to take this forward.
What was your role as CMO in relation to communication with those on the shielding, later named highest risk list in Scotland?
So, as CMO, one of the things that the policy team who was overseeing this part of the response was keen to do was to establish, if you like, a trusted route of communication to people who were shielding. That was something that I was very happy to take part in. So whether it be in terms of the numerous letters that we used to try to communicate with this group, or whether it was in the daily briefings just trying to kind of target specific information, I was quite happy to try to be a part of that. And there was a feeling, and I think it's a legitimate feeling, that communication coming from a senior clinician was better. It also meant that before communications were actually sent out to people, myself and my clinical team could look over those communications and make sure that they captured any clinical information that was contained within them, or information about risk as fully and as articulately as possible to be understood by the people that were going to be receiving. There was a lot of concern, particularly in the initial stages, that some of the information which was coming across our desks, but I don't think actually made it out to people, was perhaps too full of jargon or terminology that might not be fully understood. So working with various groups and working with the clinicians who were involved just to try to make these as plain English as possible was something which I think we tried to contribute to.
Was the question of whether the list should be extended to a wider cohort within the clinically vulnerable revisited by the CMOs?
It was revisited on several occasions, and both in CMO meetings and at the Quint meetings that we referred to this morning. There would be on occasion a proposal which would come forward with data to consider whether such a group could reasonably be asked to take this undertake shielding as part of the response to try to keep them safe. There were very few groups where the data was so compelling that we actually felt it was we should expand the shielding list to include them. As I say, given the scale of the undertaking. But there were, nonetheless, there were, I can think of 2 to 3 groups at least, where those decisions were made at a later stage to bring them onto the list at that stage. As I say, the other thing which I think worked well for Scotland and which gave us an additional degree of flexibility was in that so-called Group 7 that we had, where if a clinician, be they a consultant or a GP, felt that one of their patients was at such sufficient risk to undertake shielding, there was a mechanism by which they could be notified to the relevant central authorities to add them to the list so that they could be provided with the support necessary. And that was particularly something which worked well with some neurological conditions such as motor neuron disease and some other conditions as well. Even just the prospect of, in Scotland we have a significant issue with frailty and multimorbidity, and sometimes just the cumulative collection of diseases that people gather over the years might have been thought to put them at an additional risk that would have allowed clinicians to add them to the list if they thought it was necessary.
Is it right that the original advice was to shield for at least 12 weeks?
Yes, that's my recollection.
This was to come to an end on the 18th of June 2020, but was extended to the 31st of July 2020, is that right?
Yes, again, that's my recollection of events.
You deal at paragraphs 208 to 209 of your Module 3 statement with the approach in Scotland to the phasing out of strict shielding. Is it right that following the 31st of July 2020 there was no return to strict shielding, albeit that guidance to those on the highest risk list was amended in accordance with the level of risk from COVID-19?
That's correct. The strict shielding that we asked people to undertake in those early stages, and which was so onerous on them, I don't think was ever revisited at all. And that doesn't mean to say there wasn't periods of time when we asked them to consider additional precautions, but there was an attempt to try to move towards a more risk-based strategy where people were able to, or provided with sufficient information to be able to try to manage their own risk, recognising that you or I or anyone might have a different attitude to risk or tolerance about given what was important to them.
What was the rationale behind the shift in approach?
It was that recognition that shielding as a process had the potential to cause harm. It had the potential particularly to cause isolation, and what we wanted to do was to try to recognise that each person was different, each person had a different attitude to risk. If isolation was so difficult for them that it was interfering with their health in other ways, to equip them with the ability to be able to assess that risk for themselves and take the approach which was more suited to their risk tolerance.
Can you help with the transition phase that there was between the 19th of June and the end of July 2020 and its purpose?
Yes, I remember conversations relating to that, particularly around about the timing of when we could cease the formal approach to shielding, particularly because at that point in time wider society had already begun to open up quite significantly. We were already starting to see fluctuations in case profiles at that time.
I'd like to deal, please, with additions to the shielding list, and in particular the addition of adults with Down syndrome. And the addition to the list on the 30th of September 2020. Have I got the date right there, as far as you're aware?
It would certainly be consistent with my recollection, a date around that time.
It's right, isn't it, that this was a UK-wide decision made collectively by the UK CMOs?
Yes.
Could we have on screen, please, INQ 30470-017? This letter is dated the 30th of October 2020. It is a standard letter in your name, which was to be sent to every adult with Down syndrome in Scotland. We can see that in the first line of the letter. Can you help with why it took a month between the agreement of the UK CMOs that adults with Down syndrome should be added to the list and the letter to adults with Down syndrome in Scotland being drafted?
No, I wouldn't be able to give you an explanation for that.
I hesitate to say sent because it does appear to be a pro forma letter. Can you help at all with the time frame of how soon after the 30th of October that was sent?
I'm afraid I wasn't involved directly in the sending of these communications, other than to agree the content.
Looking at the terms of the letter, and in particular, firstly, this letter is not asking you to start shielding, but we want to talk about why we are adding you to the shielding list in Scotland. And that follows quickly upon I'm writing to tell you that you've been added to the shielding list in Scotland. Do you think it was potentially confusing for a recipient of this letter to be told that they were being added to the shielding list, but not being asked to shield?
I think the terminology was difficult at that time, because the terminology that was still in common usage by the public was that of shielding, and certainly there was a desire to move away from that as a term and to speak about people at the clinically most vulnerable as a group. With the benefit of hindsight, I would far rather have had a letter which tried to explain things in different terms there. I don't like the term shielding, I have to say now. I think it was used perhaps out of necessity as the best description that people had for what was being asked of at that time. But given that we moved away from shielding as an intervention so early in the pandemic, I think we should have moved away from the terminology and almost started afresh. The terminology is different, of course, from the identification of individuals who needed some level of enhanced protection, whether that be about how we started to sequence people in the vaccination programmes, or how we started to communicate people who might be at additional risk at times of changing epidemiology. I just think that by that stage, the term shielding was probably already out of date.
That document can come down now, thank you. In terms of review of the impact of shielding, which became the highest risk list, is it right that the Scottish Government commissioned Public Health Scotland to develop an evaluation framework for the shielding programme in 2020?
That's correct, yeah.
Did this work inform the change in approach in Scotland away from strict shielding? Or did that happen later?
I think that if memory serves me correctly, and I'm not sure, I think most of the approach, the change in the approach to shielding was actually led by feedback directly from people who'd been asked to shield. I think there were perhaps some preliminary findings from that report by Public Health Scotland which also informed the change in approach, but I couldn't say that with certainty to you.
It appears from the documents that there was a deep dive into the impact of shielding done by the COVID-19 advisory group, the Scottish group. And certainly you may have seen in the documents some evidence of feedback. Is that what you're referring to?
Yeah.
The Scottish Government Shielding Division produced a report with the results of a January 2021 COVID-19 shielding survey in February 2021. Could we have that on screen, please? It's INQ 3047410, starting on page 32, please. Under the heading Gaps in Support and Access, survey respondents were asked whether there was anything they were struggling to access at the moment to try and identify where more or additional support could be provided. The majority were struggling with challenges that are not easily addressed by government support, and there are a number of things listed there. However, there were still people struggling with access to healthcare appointments, 23%, which had been identified in previous research with this group. Many of the comments in the open text response were aligned with existing categories such as healthcare appointments and exercise, but people wanted to provide more specific information about the types of appointment they were missing out on. A number of responses highlighted challenges, which is after they returned to work, so unrelated there. What was done by you or your team to address the difficulty that survey respondents were having accessing healthcare appointments? And can you help with what the main reason was for these access difficulties?
Again, I remember conversations which took place with the Shielding Division in relation to some of the findings of this, and with other parts of the health service as well. And one of the common things that came through in feedback was the sense of fear in particular that people had in attending healthcare settings at that point in time. That was something which we found in the general population as a whole. Particularly in those early stages before people began to get vaccinated, but it seemed to be disproportionate and more evident in people who had been asked to shield as a consequence of that. There were various ways that we could try to deal with that, and one of the ways was to, where it was appropriate to do that, was to make a greater emphasis on some of the digital platforms that we were now using for healthcare consultations, such as NHS Near Me, and whether that would be a potential medium that could be...
Could you slow down, please?
Whether that could be a potential medium that would enable people to access healthcare in a way that they felt safer to do so. It didn't fix every case, because sometimes because of the underlying nature of people's conditions, these were tended to be people with chronic illness. So sometimes it meant that attending healthcare facilities or having clinical staff come into their homes to see them was necessary, and that was still a time of, I remember, great apprehension for many of them.
Setting aside the apprehension and the fear, it sounds on the face of this survey as though there was a logistical difficulty in accessing appointments. Did you see any evidence of that?
I can say that I wasn't involved in any conversations that related to logistical difficulties, but those may have taken place with other parts of government.
As a final question on shielding, is there anything about the shielding highest risk list programme in Scotland that you would do differently with the benefit of hindsight?
Shielding was a really horrible undertaking to have to be asked to do, I think. And the isolation, I don't think that any of us who were not in that shielding group can really understand what the sense of isolation and fear must have felt like. And that's in people that I've spoken to, that's the bit that comes across more than anything else. So is there anything I would have done differently? I think I would always question as to whether it was absolutely the right thing to do, but even with the benefit of hindsight, given the information that was available at that point in time, it did seem like one rational way of trying to protect people who were recognised as being at additional risk. The one bit I would change was to ensure that there was a greater degree of mental health support for people who were undertaking shielding, and whether additional supports could be made available just to reduce that sense of isolation that people felt.
I'd like to move, please, to escalation of care protocols. Could we have on screen, please, INQ 3085979, page 26. This is a statement provided by Caroline Lamb to the inquiry. Paragraph 103 here deals with the ICU Uplift Short Life Working Group, which she says made recommendations to you, the CNO and the COO, and then the Cabinet Secretary for Health and Sport. Is that right?
Yeah, I remember that was a group which was very active, particularly in the early part of the pandemic.
Of the group's work, Ms Lamb said this: the Cabinet Secretary took the final decision to implement an additional 30 Level 3 intensive care beds for patients requiring highest levels of clinical support across Scotland on a permanent basis. Is this referring to the permanent increase in ICU capacity in Scotland, which was decided upon?
So this is partway through the pandemic when the temporary increase, the doubling of ICU capacity has already taken place, with the ability to be able to go up to 3 times the previous limit. And what this group had recommended was that there should be an additional 30 permanent beds even within that structure within Scotland.
The last sentence in this paragraph says this: the SLWG did not have decision-making authority. The SLWG was reconvened in November-December 2021 with a reduced membership to make recommendations on changes to the ICU surge escalation policy. Can you help, please, with what the original ICU surge escalation policy covered?
So the original surge escalation policy was examined how the ICU beds and available equipment in Scotland would be reconfigured to allow, first of all, doubling of capacity within ICU with the ability to be able to surge further to a tripling of capacity, should it become necessary. As far as I can recollect, I don't think it ever went beyond that doubling of the capacity, but sufficient, particularly ventilator equipment, was either purchased or repurposed in order that there were sufficient ICU beds to double the capacity across Scotland through that initial work. That was a very rapid piece of work which was led by, at that point, the Chief Operating Officer, with really strong input from the Scottish Intensive Care Society. Some of my advisors within government also participating in that, and the Royal College of Anaesthetists. The equipment was available to repurpose in Scotland, particularly the ventilator equipment, particularly with the theatres being less used at that point in time. One of the rate limiting steps was in having sufficient trained staff, particularly trained nursing staff, to be able to safely provide care to all the available beds. That was looked at. People were redeployed, retrained to try to augment that working force. And I have to say that this was an area of clinical practice where I have nothing but a huge amount of respect for the huge variety of clinicians, because we should remember it's not just doctors and nurses that worked in these ICU units, but there was a whole variety of inputs from various clinicians, and the work that they undertook in often very difficult circumstances was incredible.
Was it any part of this group's role to look at escalation in care protocols? And by that I mean, for example, clinical prioritisation guidance or tools? Or is that escalation simply a reference to the number of beds?
That surge that escalation there is just about the number of beds which were available.
So logistics rather than what to do if there aren't enough beds?
Yeah.
That document can come down now, thank you. I'd like to ask you, please, about decisions which were made at UK and Scottish level about whether to issue guidance on escalation of care or clinical prioritisation, in the context of capacity challenges. Could we have on screen, please, INQ 40/48276? This is an email chain from March 2020. Could we start, please, on page 7? The email dated the 27th of March 2020. This is between DHSC employees. It refers to work which had been done on guidance on capacity challenges in critical care. And just scrolling down, please. The information contained below, which is being forwarded in this email by way of background, explains the issue. The 4 UK CMOs commissioned experts to develop guidance for clinicians on clinical prioritisation for COVID-19. It has been led by a number of people being named. The guidance has been developed with engagement and input from a number of stakeholders, including the BMA, GMC, National Voices, Royal Colleges, and a moral and ethical advisory group. It is intended to provide clinicians with a decision-making protocol for use during the COVID-19 outbreak when ICU beds are in unprecedented demand. Although clinicians ordinarily make ethical judgments as part of their work, this tool would bypass usual processes and is intended for use when judgments must be made quickly and possibly by more junior clinicians. The protocol is based on a scorecard system which takes into account age, comorbidities, and frailty to determine the most appropriate clinical pathway for an individual in the event that there are not ICU beds. It is intended to provide a fair, consistent, ethical, and compassionate framework for clinicians to make decisions about critical care pathways. Going up a page to page 6, please. There is an email about halfway down the page sent the same day, again between DHSC officials. And it says, "Hi both, I just spoke to an official who had just come out of a meeting with the 4 CMOs and the guidance team. They want to send the guidance and the graphics to ministers for clearance on Sunday afternoon, ideally. So we agreed it would be important to have the comms handling sent up at the same time, as ministers, CMO, are likely to have strong views on how this is communicated." Going to page 2, please. And the email dated the 28th of March, 2020. In the middle of the page, I've just heard from CMO's office that this isn't going to ministers tomorrow and has been paused for now. And then underneath, we can see some bullet points there. SOS and Simon Stevens have spoken and have cancelled the ministers' implementation group tomorrow. It was due to be 11 a.m. and specifically to discuss the clinical prioritisation tool. This is because both are unhappy with issuing this tool as it stands, noting how potentially controversial it is / difficult landing. And finally, going up to page 1, the email dated the 30th of March. And this is from the private secretary and deputy head of the office from the CMO England's office. This is now paused indefinitely, possibly never to be picked up again, now that there is less or no need for it, given early signs suggest demand may stay below capacity. Taking this in stages, can you explain, please, Professor Smith, what work the UK CMOs commissioned and why?
I wasn't involved in that, so I'm afraid I can't explain that. This predated my time as CMO and I wasn't involved as DCMO.
You had no involvement when you were in your DCMO role?
No.
Did you receive any handover from your predecessor about this?
No.
Were you aware that this work had been done at all?
I was aware during March that there was some work which was being looked at in relation to escalation policies, but I'm afraid I wasn't in any way involved in it.
Does it follow that you can't assist with who decided that there would be no UK-wide guidance issued on clinical prioritisation?
I'm afraid I would be unable to offer you any insight into that.
Okay. That document can come down now, thank you. Did you consider whether such guidance was necessary?
I was aware that there was similar guidance which had been put in place as a document in the response to pandemic flu, written by NHS England in the early 2010s in relation to what steps may be necessary if a health service became overwhelmed with cases of a pandemic flu. At that point in time, in the pandemic response, although it was certainly becoming evident that there was going to be quite significant pressures on healthcare services, the agreed strategy, if you like, was to try to expand the capacity of key points of the service rather than look at these type of escalation policies.
Did you give any consideration to issuing such guidance in Scotland, regardless of what the UK position was on guidance?
No.
The last email we looked at suggests that the decision to shelve the draft guidance was ultimately made because it was felt that capacity would not be reached after all. Would you agree with that reading of it?
Certainly, the capacity with the ability at that stage in the modelling we were receiving, suggesting that there was still sufficient capacity should we need to increase, if you like, the next stage of surge planning, which was to increase the capacity in ICU to 3 times the original limit, that we still wouldn't breach that capacity. I wouldn't have said that there was a need to address that through this type of guidance or policy, whatever you want to call it, at that stage.
Research conducted on behalf of the inquiry for Module 3 by way of a survey of 1,683 healthcare workers in the UK is summarised in the report at INQ 304995523. Can we have that on screen, please? Have you had an opportunity to look at this report?
I have, yes.
If we could go to page 14, please. It is reported here that for both the first and the second waves of the COVID-19 pandemic, over half, 54% of respondents reported that some patients could not be escalated to the next level of care due to lack of resources. We needn't go to it unless you wish me to, but the executive summary also records that A&E doctors at 71% and paramedics at 62% were more likely to have been unable to escalate care due to a lack of resources at either wave. Accepting that it's not possible to know what proportion of the respondees were based in Scotland or the relevant areas, do the results of this survey surprise you?
In some sense, they do. So particularly, they don't surprise me in terms of the overall capacity within hospitals, which was running at a level which was really quite. The number of people who were in hospital was really quite immense and exceeded capacity on several occasions, with hospitals having to adopt novel approaches to how they used other clinical areas to effectively provide care in as well. Where it surprises me is that given that there was the ability to be able to, certainly in Scotland, and I can only speak for Scotland in these circumstances, to expand the capacity for care further, particularly with ICU capacity, and the fact that we at no stage went in to that further expansion of capacity, it surprises me slightly from that perspective, that was never necessary.
Were you told at any point in the relevant period for Module 3 that resource-based escalation of care decisions were being made in Scotland?
No.
That document can come down now, thank you. I'm helpfully being told, could we have that document back up, please? The bottom of page 8, please. We can see that there are 138 of the respondees were from Scotland, which is about 8%, just to make sure that we're being complete about it.
Yeah.
That document can come down again. Thank you. Had you become aware that healthcare workers were finding themselves in the position of having to make resource-based escalation of care decisions, would it have changed your view, or would it have informed your view on whether there was a need to have a clinical prioritisation tool or set of guidance?
So I think, first of all, I would have wanted to fully understand exactly why people's perception was that they were unable to escalate care and what resources were limiting that factor. And if that was a resource which could be rectified, which could be addressed, either through expanding into pre-planned surge capacity or by additional equipment, my preference would certainly have been to make sure that we were taking steps to do that. If, however, it was an issue of overwhelming demand that was meaning that people could not expand beyond the existing capacity, either through lack of equipment or lack of space to expand into, then I think that leaves very, very difficult decisions for clinicians. It's one of the reasons that during the early part of the pandemic, in Scotland certainly, we set up a network of ethics committees within each of the health boards to assist clinicians when they were faced with difficult decisions about treatment for patients. Those ethics committees provided support to clinicians in each of the health boards, but there was also a central ethics committee that they could refer back to if necessary, or mutual aid if an ethics committee in one area in particular became overwhelmed by requests. And that would have been a second stage, I think, prior to adopting a formal escalation policy, because let's be clear, by adopting an escalation policy, we're asking clinicians to make very, very difficult decisions about who goes onwards for particular types of treatment and who doesn't. Often that's clear-cut. That's the role of clinicians, to be able to do that, to be able to take decisions based on the clinical evidence as to who might benefit from a treatment or for whom, unfortunately, we have to say a particular path of treatment is futile and is the wrong approach. But what we were potentially asking patients to do if the service was becoming completely overwhelmed in those circumstances, really asking clinicians to kind of pre-select and judge, even when treatment may have some beneficial impact, who should go forward for that as well. So that's not a place that any clinician or anybody wants to be, and therefore I would see an escalation policy that started to outline that type of approach as very much an approach of there's nowhere else to go and nowhere else to explore first.
How should this information have got to you? If this is how the healthcare workers felt, I appreciate it wasn't by any means a perfect world, but what would be the system for getting that information to you or to people at your level?
I mean, it would usually rely on chains of communication. So, particular areas were reporting that there was a clinical governance issue. And I'm going to use an example of, let's say, an acute medical ward, which finds that it's so overwhelmed with seriously ill people, but can't escalate out of there to ICU. So that would be a clinical governance incident, if you like, which would, at a local level, using the local governance structures, would be looking to see what they could try to do about it.
There ought to be in place a chain of communication that would then get the information.
And that relies on the regular dialogue that we have, certainly from my position with medical directors around the country, from a medical director's point of view, with the clinical directors that they have within their hospitals and so forth. But it relies on that chain of communication being as strong as possible. There's also, it has to be said, that in Scotland certainly, and I can again only speak for the Scottish experience, there is the ability for people who feel that their concerns are not being addressed or listened to, specific whistleblowing channels that people can take to raise that information as well.
Thank you, my lady. Any consideration that was given to whether there should be guidance issued on this subject, would it have been an important consideration to assess the impact, particularly of a scoring system, on older people and those with comorbidities or disabilities? And would that consideration have formed a factor in the decision one way or the other?
It would have to have been an important part of the consideration, is to look to see how this was impacting in different groups. I think, and I think that's the basis of my point here, is that what we're should you enact a policy like that, you have to be very, very clear about the ask that you're making of people and how that impacts on individuals and their families.
Turning, please, to the use of DNA CPRs, starting, please, with the policy and guidance on this. Mm-hmm. Is it right that there was in place before the pandemic a do not attempt cardiopulmonary resuscitation policy dated August 2016?
So there was a policy in relation to DNA CPR which formed part of a wider process which was about anticipatory care planning.
Could we have on screen, please, INQ 30429-278? This is the policy which is dated August 2016. Going to page 17 of the document, there is a section on advanced decisions about CPR treatment. And the paragraph underneath the heading says, advanced decisions about CPR can be difficult and can cause considerable emotional distress. But when discussed in the context of goals and care and choices about available treatment options, they can also be extremely reassuring and a huge relief for some patients. There is evidence that patients experience conversations about DNA CPR as positive and empowering when they happen within the context of wider discussions about emergency care planning and end-of-life care goals. The appropriateness of CPR should always be considered on an individual patient basis. There is never a justification for blanket policies to be in place. And then it goes on to set out the two situations in which an advanced decision that CPR should not be attempted can be made. So it was clear from this guidance, wasn't it, that DNA CPRs should always be considered on an individual basis, and there is never a justification for blanket policies. Would you agree?
I agree very strongly with that.
Could we have on screen, please, INQ 30429-276? This is a letter from you to GP practices and chief executives of NHS boards dated the 10th of April 2020. The letter deals with anticipatory care plans for vulnerable and high-risk patients, which a DNA CPR might be part of, but should not be equated with. Is that right?
And I think that's a very important point that you've picked up on there as well, not to conflate the two issues of anticipatory care planning and DNA CPR. Anticipatory care planning is a much wider approach to how you express preferences of a patient in the way that they receive their care. DNA CPR may be a part of that, but does not have to be a part of that, and that's an important aspect of this type of ACP planning.
You refer in this letter to an earlier letter which was sent to GPs and hospital clinicians addressing plans for supporting patients identified as being at the highest risk of mortality and severe morbidity from COVID-19. That earlier letter included the wording in bold towards the bottom of the page, which says, in addition, for some patients in this group, it may be appropriate to discuss their anticipatory care plan. This discussion should be done by a clinician, but again, it doesn't have to be a GP. The letter goes on. In fact, for many patients in the very high risk group, it would be more appropriate for them to have their ACP conversation with their treating consultant, who may be in a better position to discuss appropriate treatment options based on the patient's individual circumstances. The reader was signposted to an ACP template. There are some key points about ACPs set out in the letter. And then at paragraph 4 over the page, please, there is this. We recognise that DNA CPR discussions are always difficult ones to have, even more so when being done over the telephone. It is also recognised that CPR has a very low chance of success when cardiopulmonary arrest is in the context of severe COVID illness. Therefore, we would like to reassure clinicians that there is no specific requirement to have a DNA CPR discussion as part of this ACP conversation, unless the patient raises this and wishes to discuss it, or the clinician feels strongly that they need to discuss it. Instead, the focus should be on supportive discussions with patients about what matters to them should they fall ill with COVID. The HIS ACP template provides a framework for your discussions with the option to complete the DNA CPR section if this is discussed. And then there's guidance about difficult conversations attached to Annex B. The inquiry understands that there was a statement made on the 7th of April 2020, so just before this letter, by a group of UK age sector organisations, including Scottish Care and Age Scotland. And they raised concern that blanket decisions appeared to be being made around the care and treatment options available to older and vulnerable people who had felt pressurised into signing DNA CPR forms. Do you recall that statement being made?
I don't recall the particular statement you're referring to, actually. What I do recall, and just to expand on my answer there just a little bit, I do recall that we had become aware from feedback from sources, and I can't remember what those sources were, that there were some concerns about the interpretation of how ACPs were being conducted in some places.
Okay. The reference we looked at on the first page of the letter, the wording in bold from the previous letter, was there a concern that that previous letter had been interpreted wrongly as saying that DNA CPR conversations should be happening?
I don't recall any specific concern in relation to that, but given the concerns that were being raised from other sources, one of the things that I wanted to do was to reinforce actually what the purpose of the letter was, and that was to have good conversations with people about their wishes for care. And to be able to, one of the important aspects of the anticipatory care plan is to be able to capture that in a way that is shared across the healthcare system. It seems ludicrous in this day and age, but we don't have systems that talk to each other across primary care into secondary care. And so we rely on mechanisms such as this. And in Scotland, we have this instrument we call the electronic key information summary that acts as if you like, a portal and a conduit in sharing the most important information about people's care from that primary care setting into a secondary care setting.
Okay.
And this was really an attempt to make sure that we had got this right and that people were concentrating on the information that was relevant and important to people about their care and not to be conflated with anything else.
At the time of writing this letter, were you aware that there were concerns of blanket policies,
yes,
the lack of individualised assessment?
I would be. I couldn't say for certain that I would be aware that this was being interpreted as a blanket policy, but I was certainly aware by this stage that there were concerns about the interpretation of how some of these conversations were being conducted.
So what I want to understand is what this letter was aiming to address. Was it aiming to address reports of inappropriate use of DNA CPRs?
So primarily to address the importance of getting the right information in an ACP, and please don't be distracted by conversations around about DNA CPR, but if you're going to have them, do them in the proper way.
If there was a concern being raised about blanket policies, something which is clearly not justified on the face of the policy that was in place at the time, wouldn't it have been better to say that in terms in this letter?
I don't think that, well, I couldn't say to you whether we had that information or not at the time that this letter was written. I do recall being questioned by a journalist about it at one of the lunchtime briefings that I gave, but I couldn't say with certainty whether that was before or after this letter was written.
Did you see any evidence of a correlation between the use of DNA CPR notices and the availability of beds, staff, ventilators or oxygen supply?
No.
That document can come down now, thank you. Could we have on screen, please, INQ 30236-625? This is the statement of Jim Elder Woodward on behalf of Inclusion Scotland. Going to page 11, paragraph 40, there is this. There is an absence of official data on the number of DNA CPR notices made during the pandemic. In England, the Care Quality Commission was commissioned by the Department of Health and Social Care to conduct a special review of DNA CPR decisions taken during the COVID-19 pandemic. No equivalent investigation has taken place in Scotland. Do you agree with Mr. Elder Woodward's observations about an absence of official data on the number of DNA CPR notices made during the pandemic?
I would agree, and I have to say that I've never seen any data in relation to that.
Is it right that there has been no review in Scotland of DNA CPR decisions taken during the pandemic?
You could certainly question as to why there hasn't been a review.
Well, my question, first of all, is that right that there hasn't been?
Yeah, I mean, I think it's a reasonable question to ask, to which Scotland would not have an answer.
Okay. So you can't help with why there has been no review?
No.
Do you consider that such a review should take place?
If the data were available to be able to provide an accurate review, then it would certainly add additional learning into the practices that were undertaken at that time. I would, my own view is that it would be more useful not to examine just the DNA CPR notices, but also to examine the wider ACP production at that time, and to try to determine how useful they had been in terms of the care that was provided.
I'd like to turn, please, to stay-at-home messaging. You refer at paragraphs 229 to 230 of your statement to reports that during the stay-at-home messaging periods, there was anecdotal evidence that urgent suspicion of cancer referrals was falling, and that some data suggested reduced presentations at emergency departments for chest pain or myocardial infarctions. What did you and your team do to address these concerns?
This became a concern that people, either through altruistic motives or through, as I think I've said before, through apprehension and fear of attending healthcare facilities, that they were simply avoiding them, even at times when they were particularly ill. The data suggested that presentations for chest pain and myocardial infarction at emergency departments was substantially lower than we would have expected. And given that illness is not suddenly going to change within a population, that was a great concern. But also urgent cancer referrals had dropped off really quite significantly as well. And again, there's no logical explanation as to why that should happen. So it suggested that there was unmet need within the population. So trying to address that was about allaying fears about presenting and trying to discourage those particularly who had altruistic motives to put those aside and to seek the help that they required. So through various communication channels, mainstream media, through our lunchtime briefings, through social media, try to kind of really raise the message that, and certainly in Scotland, the message was not protect the NHS, but actually, if you've got a problem that has serious and significant symptoms, particularly if those symptoms are lasting, then you should seek attention for it.
Do you think that the stay-at-home message got the balance of risk right? That is, the risk to people contracting COVID-19 with the consequences of that risk, and the risk that people would take the message at face value and not seek medical help if they needed it?
I think the stay-at-home message by itself probably got the balance of risk right. I think where additional messaging was layered on top of that. So I think the stay-at-home message had to be layered, nuanced, and be accompanied by, however, if you need medical attention, you should continue to seek it. There was perhaps messaging from other parts of the UK at that point of time, which was less useful in terms of influencing people's way of approaching care.
Coming finally, please, to lessons learned and recommendations. Looking back at both the things that went well and the things that went less well in the Scottish healthcare system response to the pandemic, are there any key lessons learned or recommendations that you'd like to tell the Chair about that we haven't already covered?
One of the things that I think was really evident in terms of the response was just how flexible, agile and committed our staff was over the whole course of the pandemic. I think in retrospect we were too slow to provide support for those staff, and that's something which we could have looked at a much earlier stage, particularly psychological support, safe space for them to debrief, in particular after what was quite harrowing experiences for many of them, and that's something which I would like to have seen more of. I think that there's many lessons that we learned along the way and that we adapted. I mean, the sheer scale of the response and the way that we were able to deploy new ways of treating people so rapidly. When you think that research in normal times takes sometimes so long to be applied consistently across practice, and yet sometimes within days, people were completely changing their approach to care, whether that be through the greater use of anticoagulation, through the greater use of proning, or introduction of new agents such as dexamethasone. The speed at which that was done was really quite incredible. And I think if there's any learning for me, it's actually about how you then replicate that in normal times to make sure that breakthroughs, advances in therapy are consistently replicated in that same way for the future. And we innovated very, very quickly. So platforms, again, like I've mentioned, NHS Near Me, and the way that was went from a fairly small scale project, nonetheless really useful, particularly for patients in a rural environment, to a digital platform that was then used extensively right across Scotland, and actually not only supported care at a difficult time, but perhaps even enhanced care, because people were suddenly able to attend with others, perhaps were enabled and supported to ask questions that they should be asking about any aspect of their care So NHS Near Me, that type of innovation, I think is something which, again, we'd want to make sure that in the future we don't embrace. But the biggest risk for me just now in all of this is that given what we have done over the last 5 years with the healthcare system, how we have expanded, innovated, how we've valued it at times, is that we lose sight of the fact that healthcare has to continually evolve, and it's an expensive business, and we must continue to make sure that we invest in our healthcare system, our healthcare workers, in a way that allows us to keep pace with the innovation and developments that are necessary to make it a much more resilient and sustainable service for the future.
My lady, those are my questions. Perhaps that's the appropriate
It is. Thank you
break.
very much. We'll come back at 25 past for the last session. I promise you we'll finish today.
Thank you.
All rise. Ms Mitchell, I think you're going first. You've been asked questions by Ms Mitchell before, so go ahead.
We've heard earlier in the evidence about the complaints from healthcare professionals about the lack of PPE. I'd like to ask you about the experience of the Scottish COVID Bereaved, whom I represent, as instructed by Amar Anwar and Company. We've heard that when visiting hospitals, there was insufficient PPE for them to use. On occasions, they were asked to use their own. Firstly, were you aware of this difficulty?
I have to say to you that no, I wasn't aware of that type of difficulty that people were experiencing.
Earlier in your evidence, you also spoke about chains of communication and dialogues with clinical and medical directors. Should you have been made aware of it?
It would probably have come up through a different route if it was being escalated to Scottish Government, to be honest. It would probably have come up to a route where the responsibility for the provision of PPE and IPC lay, rather than through the channels of communication that I had.
But should you have been made aware of it?
I would certainly like to have been made aware of it.
And if you had been made aware of it, what could you have done about it?
The most important thing that I could have done in that circumstance would have been to engage both with colleagues within Scottish Government, but also with the locations where people were experiencing particular problems, to make sure that adequate supplies were made available to people. And
just taking that point and moving on from our leadership's questioning earlier, does that mean that there is some lacuna, or there should be some lacuna fixed to ensure that the CMO is getting information from, as it were, the hospital floor that you would be interested in? Is that something that could be remedied in the next pandemic?
So in that specific example that you're giving, whilst I would have been interested with it, if you like, the chain of governance that existed there would have been through the infection prevention and control policy areas that have the levers to try and address any problems that are there. So that would have, as I say, although I would have been interested in that, the Chief Nursing Officer would probably have been equally, if not more, interested in learning that there were issues with that.
Moving on, in respect...
So just before you do it, it won't come out of your time, Ms Mitchell, don't worry. I'm just getting the impression, I mean, you're meant to be advising Scottish ministers, but because you have all these different subgroups, specialised groups, there are different chains of communication, and it's not coming to you. How can you advise Scottish ministers properly on policy if this information isn't coming to you?
I guess because I'm one of many advisors to Scottish ministers, all with specific areas of remit around about the advice that they provide. So the Chief Nursing Officer, for instance, would provide specific advice to Scottish ministers in relation to infection prevention and control. And that usually wouldn't be an area that the CMO would provide or be the prime focus of advice to Scottish ministers.
I'm obliged. When Milady looked at me, I actually thought she was meaning for me to move on rather
no.
than to follow up. So that's why.
I was wondering if I could interrupt.
No, that's why I didn't do that. Moving then on to a further issue. Again, another experience of the Scottish COVID Bereaved was that when trying to visit loved ones, different health boards, hospitals, wards even took different decisions in relation to visiting. The decisions weren't consistent, including whether or not end-of-life visits would be allowed. Were you aware of this inconsistent approach being used?
I wasn't aware of the inconsistent approach, but I was very clear at all times that end-of-life visiting was an incredibly important aspect of the care that people were able to provide. It was really important that people could have time with loved ones at such an important moment. I was... it's possibly not correct to say I wasn't completely unaware, because there were one or two instances I remember which were discussed and which were then taken back to individual units or hospitals by the person-centred team who looked after this to try to make sure that they were adopting and interpreting the policy correctly.
Well, it's certainly the experience of the Scottish COVID Bereaved that a number of people didn't get to visit their loved ones before they died. And these inconsistencies have caused much distress to the members of Scottish COVID Bereaved and no doubt others not in the group, some of whom are finding out that others were able to visit their loved ones and they blame themselves for not having, for example, pushed hard enough or tried to escalate matters to get them to be seen. Ought a consistent approach to have been taken to those visits, and how can we ensure that happens in the future?
The first thing to say is I'm very sorry to hear of that experience that people had, and I can only imagine the impacts that that's had on them, not only at the time, but the enduring impact that it's had. And you're absolutely right to say that there should have been a much more consistent application of that approach across the system.
I wonder if I could now move on to DNA CPRs. We've heard, one of my questions was, do you agree that the blanket approach ought not to be used? And we've heard in strong terms that you say it shouldn't. Can I just check with you on that question? What do you actually mean by blanket approach? What is it approach of or to?
What I will tell you should happen, rather than what shouldn't happen, is that any discussion with any person or their family, if the circumstances dictate that, in relation to anticipatory care planning or DNA CPR should be individualised to that person, should be mindful of the circumstances which they find themselves in. And I really struggle to see how any approach to proper anticipatory care planning or DNA CPR can be conducted if it's done in a blanket fashion without recognising the individuality and the preferences of a person who's at the centre of it.
Can I just check, do you mean a blanket approach in relation to, for example, classes of people, or a blanket approach as in a one-time decision taken on DNA CPR which covers the future of that person's healthcare?
So I mean both. Because one of the most important aspects of anticipatory care planning, and again I use the broader term here, DNA CPR being part of that, is about the need to continually review that process that's been done, to revisit it. It's a dynamic process rather than a once and done process.
So you would agree that each decision should be taken after consultation with the patient and, if possible, their family?
Yes, and it should be revisited at an appropriate timescale as well.
Are you aware, as CMO, of any breaches of professional codes of practice or ethical practice in Scotland in relation to the use of DNA CPRs?
I am not aware of any of those breaches, and I have not been made aware of any cases that have been taken by any of the regulatory authorities against any clinicians in relation to that.
And again, I suppose following up on the first question, should you be aware, or should someone be making you aware of the answer to that question?
So if those, in Scotland we have a series of what we call responsible officers, particularly, and I can only speak to the experience of medics here in the system, doctors in the system. And the first point of call, should any of the regulatory authorities, in this case the GMC, be taking action against any clinician because of a breach of their professional responsibilities, and in that case would be to their responsible officer at a health board level. It wouldn't be escalated to the CMO unless there was a suspension put in place for a particular practitioner, or I'm trying to think of any other circumstances where it might be escalated to me in normal times. Really, it's only if someone was suspended, or if there was such a pattern of an approach that GMC felt it was necessary to notify me of it.
I'm just over my time, so I'm obliged, my lady. Perhaps if there is such a review, those matters could be looked at.
Thank you, Ms Mitchell. A special what in place? You talked about it won't be escalated to the CMO unless there was a special something rather in place, and both I and the stenographer missed it.
Okay, so it wouldn't be escalated to me unless there was a theme that emerged that was so important that the GMC felt it had to be notified.
A special theme. Is that the word? Thank you. Can I just go back, pursuing the questions that Ms Mitchell asked, to the point about revisiting DNA CPRs. You talked about them being time limited. I mean, I'm just a bit troubled by this idea that I might go to see a GP on X day and agree on care planning because I'm feeling a huge amount of pain and I'm feeling pretty low, and I might say, you know, I've had a good life, that's it. But then the pain might ease a bit, and I'm just a bit concerned about this idea that I might say, do not attempt to resuscitate me, but then it gets transferred when my circumstances have changed. So help me when it comes to when you talk about ought to be revisited and within a certain time period, what kind of circumstances are they?
So we have to be very clear about the circumstances, and if we go back to the document that was showed by Council in terms of the guidance of the circumstances when a DNA CPR conversation might be appropriate for someone. And generally that's when it's evident that actually the process of CPR would ultimately be futile in terms of achieving its aim of resuscitating someone whose heart has stopped. Okay, the circumstances that you're describing there, for me, wouldn't really warrant a DNA CPR conversation. It would warrant certainly an ACP to be formed about the preferences for your care. But we're not in a situation that you've described there, whereby approaching CPR would actually be a kind of futile response to your circumstances.
So basically, every decision ought to be a clinical decision. So even when whatever the patient has agreed with the GP, when the patient gets to hospital, it ought to be a clinical decision by the hospital doctors, after consultation with the patient and their family, if possible.
That should be the case in every aspect of care. Every aspect of care should have an element of what we call shared decision making in it.
So you can't have any transfer of agreement to.
That is the purpose of ACPs, is to be able to express within the ACP what certain preferences are, so that can then be picked up by the hospital clinician, and it acts as a really good starting point for the conversations with people about the care that they're going to receive.
But it was only a preference expressed at that time.
Exactly.
It should still remain the clinical decision on the day.
And shared decision making must be the method by which we undertake any of that decision making.
Thank you. Mr Dale, where are you? There you are. Can you see Mr Dale over there?
I ask questions on behalf of the COVID-19 Airborne Transmission Alliance, or CATA, and I have a few questions. There was a step down from FFP3 to FRSM, which occurred in mid-March 2020. CATA considers this to have been driven by lack of resources, a shortage of FFP3s for healthcare workers. Do you agree that the moral and ethical position should have been to inform healthcare workers of the shortage and assure them that the appropriate protective equipment would be provided as soon as possible.
I'm not aware that there was such a critical shortage that they weren't available for the appropriate circumstances that had been identified by the expert groups who were examining this just now. So I'm not sure I understand the whole nature of your question there.
Assuming that that proposition is or CATA's contention is factually accurate, would you agree that it would have been the appropriate route to take, that is, to inform healthcare workers of the shortage and assure them that the appropriate protective equipment would be provided as soon as possible?
We appear to be talking about a hypothetical situation here, and I guess the point I would make in response there is that communication and dialogue is really important with people as to the reasons why any particular route is being taken. And in the circumstances, again, I go back to my point, is that the level of PPE which had been identified by the expert groups was identified on the basis of the evidence that was available to them and wasn't dictated by supply chains at that point.
Very well. My next question. Do you accept that a significant number of healthcare workers might have lost trust in organizations or institutions that are supposed to keep them safe in terms of guidance and so on?
I think that there was a very marked response from clinicians at that point in time, and as a result of their experience, and many of them felt let down by the organisations they were working for. I think that's evident from the survey of which we have already examined earlier on today, and some of the feedback, which was certainly evident through the BMA membership. The reasons for that, I think, are complex and deal with a range of things from supply issues which were evident in some places through the personal risk that people thought that they were personally experiencing as a result of them working in a very hostile environment, I have to say, at times in terms of their busyness and overloaded with various considerations as they tried to kind of treat cases, but also just because of the conflicting information which was very evident at that point in time, and I think that conflicting information, some of which had unfortunately no basis, led to a reduction in trust in people.
Are you concerned that this loss of trust, such as it exists, might have implications for future pandemics when healthcare workers weigh up the risks to themselves and their families if they do go out to work?
I think there's lots of learning we need to take from this last pandemic, and the purpose of this inquiry is to try to distill as much of that as possible so that we can learn from it and implement that in the future. I think much of that, as stated towards the end of my own evidence, was about how we value our workforce and how we support them to do the jobs that they want to do. Is it becoming increasingly evident for many reasons that the number of people choosing careers in healthcare is falling. Now, as I say, the reasons for that are very complex. But there's never been a more important time to make sure that our workforce does feel valued and is given the proper equipment and capacity within their teams to do the jobs that they come to work to do.
Mm-hmm. This is a reflective question. Do you believe today that the approach that was taken then was consistent with the precautionary principle?
I believe that the approach that was taken at that point in time was consistent with the precautionary principle on the basis of the evidence that was available at that time.
In what you refer to as the second meeting with our Dr. Gillian Higgins in April 13, 2022, and this was in her capacity as founder of Med Supply Drive UK, which is a charity that was set up to address issues of appropriate RPE for healthcare workers. During this meeting, Dr. Higgins suggested a range of manufacturers and universities that might help, and this is referenced just for the record at paragraph 62 of her statement. And I should point out, by the way, that she states there she declared a complete absence of any commercial interest in the potential sources of reusable respirators. So healthcare workers were, at the time of your meeting in 2022, they were being permitted to request RPE. But the meeting, it was clarified, the point of it was really to allay anxieties and concerns about safety rather than an acceptance of the scientific evidence on the airborne route of transmission. In light of the expert witness evidence provided to the inquiry to date, what is your understanding now of the route of transmission of COVID-19? That is, do you accept the airborne route of transmission of COVID-19?
So I think we've already gone over this, and the evidence that are given today is that there are a variety of ways that COVID is now known to transmit. Through droplet, through short and through longer range aerosol. All of these, there's a much greater degree of evidence now for those routes of transmission than there was. There's less evidence and less thought about the kind of spread through fomite routes that were thought to be more important in the early stages of the pandemic. But it's my view, and as I've stated earlier on today, I have held the view for a long time that aerosol transmission has certainly played a role.
And finally, do you support a change in the current guidance in the National IPC Manual, given the evidence the inquiry has heard about airborne transmission?
I am confident that the IPC cell will continue to keep all available evidence under review, and based on that evidence will make the best recommendations for what protective equipment should be used and how IPC should be approached.
Thank you.
Thank you very much, Mr. Doyle. Mr. Wagner.
Good afternoon. Hello, my name is Adam Wagner, and I ask questions on behalf of the clinically vulnerable families. I want to ask you first, please, about the recommendation in relation to face coverings for the general public and the fact that FFP2 and FFP3 masks were not specifically recommended. And I want to ask you about one subsection of the public, which is hospital patients. Do you accept that the risk of being infected with COVID-19 in hospital was at times high?
The evidence would certainly suggest from nosocomial data that there were points in time when there was a high risk of infection within hospital.
And do you accept the evidence from Professor Beggs? If I refer to Professor Beggs, do you know of that evidence that's been given to the inquiry?
Could you expand on that?
Professor Beggs has given evidence about the routes of transmission, particularly for the inquiry, and also he's given some evidence as an expert on FFP2 and FFP3 masks. And one of the things he says, and I want to check whether you agree with this or not, is that FFP2 and 3 masks offer good protection to the wearers of the masks from inhaling infectious aerosols as compared to surgical masks or face coverings that don't.
So there is certainly evidence that FFP3 masks give the wearer more protection against inhaling aerosols. There also comes, unfortunately, with the downside to wearing those type of masks as well, which is often overlooked, and that's the length of time to which people can generally wear them comfortably, and also some of the skin problems that people suffer as well as a consequence. But I think it's generally accepted that FFP3 masks give more protection than the other masks, such as fluid-resistant surgical masks.
Well, bearing those 2 points in mind, the high risk of COVID-19 in hospital at times, and the fact that FFP3 masks give higher protection against aerosol transmission, do you now think it would have made sense to recommend FFP3 masks for at least some hospital patients?
That would have been something which could have been risk assessed in local circumstances, but it would have been an onerous undertaking. And guess we should remember that the masks, the personal protective equipment, were only part of a range of protections which were in place, each one layered on top of each other, which gave protection to both patients and staff within hospitals. And the consistent application and implementation of all measures of that under that hierarchy of controls was certainly one of the most important aspects in the kind of research findings as to how you provided effective protection within hospitals. So it may not have added a huge amount of additional protection, and could have added something at a cost to the individual wearer, particularly if asked to wear them for long periods of time within a hospital bed.
But it may, would you agree, it may have added some protection for those, particularly for vulnerable patients?
It may or it may not. That's yet to be determined, I think.
What about in July 2020? And I just want to ask, you gave evidence earlier about clinically extremely vulnerable people being given advice as to shielding once the shielding programme was ending. Should they have been advised about the potential benefits of wearing higher grade masks like FFP3 to help them more safely return to the community?
My own view on this is that, with the benefit of hindsight, given the fear and apprehension that many people experienced at that point in time, then it's something that could certainly have been considered as to whether the provision of those masks, type of masks, would have given them greater confidence to re-establish themselves in society.
You say it could have been considered. Should it have been considered?
Again, we go back to whether it would have given, in the real world, an additional amount of benefit which would have actually protected the patient, particularly with those kind of higher grade of masks where fit testing is necessary as well. Sometimes, if not worn properly, if not applied properly, it can give a false level of reassurance that actually could be detrimental.
But that can be overstated, can't it? Because it's a 10-minute, 15-minute fit test, and then it's done.
If people are able to apply it and use it consistently.
Yeah. I want to ask you about the Chief Medical Officer's technical reports, which you were shown earlier. It says in the IPC section that feasibility of implementation was one factor in choosing to recommend that the public wear face coverings rather than particular masks. Once the supply chain pressures eased for the higher grade masks, do you think recommendations about mask wearing should have changed for the general public?
My own personal view is no.
Do you want to expand on that?
Again, I go back to the acceptability of for the general public of particular approaches, and to mandate particularly high levels of mask wearing for the general public, I think would have been the biggest risk with that would have been to ensure that more people didn't follow the guidance in relation to when you're wearing particularly the highest grade of mask for prolonged periods of time, it can be quite an unpleasant experience. And I think there were points of time in the pandemic where you could begin to see that even wearing the lower grade masks was something which many members of the public found difficult.
What about the public guidance? And I'm talking about guidance, not mandates here, but what about the guidance explaining relative benefits of one kind of mask over another? Do you not think that would have at least allowed people to make their own decisions about whether, on the one hand, there's the possible discomfort of wearing the mask, the 15-minute fit test, and on the other, there's the risks to them of, particularly for vulnerable people, of getting COVID? Do you not think it would have been better to have that, put that in the hands of the public rather than just saying face covering is fine?
At this stage, it's difficult to give you an answer to that, I have to be honest, because it would have been interesting to know to what level many members of the public wanted to protect themselves. Many of these masks were freely available to purchase. The FFP3 masks were more difficult to come by, and as I say, had to be preceded by fit testing to make sure that they were appropriately used as well. I don't know where the public's mind lay on all of this. It's something which could have been explored, but unfortunately it wasn't.
I want to ask you about the implementation of the shielding policy. And I appreciate that you explained before that you weren't as involved in the earlier stages of shielding as you were in the slightly later stages. I think it's right to say that the UK chief medical officers were tasked with identifying which people should be classified as clinically extremely vulnerable and therefore go onto the shielding lists. Now, in England, there was then a division where I think NHS Digital were tasked with tracking the people down once the groups were identified as a cohort. And they had some difficulties accessing that data. And there's a national audit report, for example, that says it took 3 weeks from when a decision was made to expand the shielding list initially to getting those names on the list, getting the letters out. Do you know whether any of those kinds of issues were replicated in Scotland?
I recall that there was huge efforts made, both within the digital teams who worked primarily in the organisation, NHS organisation, NSS, but also working with clinicians, particularly in general practice, to make sure that the correct coding was in place for patients who might need to shield. Without that clinical coding in the digital electronic record, it was very difficult to identify patients. And it has to be said that in not all instances was that coding leading to the identification of people who either should be shielding, or sometimes it led to the identification of people who actually didn't require to shield, although that was less seldom a problem. The way we tried to overcome that in Scotland was to give some flexibility for clinical teams to add people to the list themselves if they felt that their patient was at sufficient risk. But there was a period of intense activity to make sure that data sharing arrangements were in place to be able to identify them.
Did you or your office give any advice when developing and maintaining the shielding programme about how many of the people who fell into the clinically extremely vulnerable cohorts lived with other people, and particularly with other people who weren't shielding?
We didn't give specific advice, nor were we asked to give specific advice in relation to that, but it was a consideration that I remember being discussed on many occasions about the impacts, not only on the clinically extremely vulnerable people, but also on their families and family life as well.
Yeah. And so when designing or amending the shielding programme, did you consider and take into account the feasibility and the real world challenges of individuals who were asked to shield, who lived with other non-shielding people, for example, with children who had to go to school every day?
Those things were discussed frequently. I remember conversations about the difficulties taking place.
And was it ever considered whether the focus should be changed or amended so that you weren't just advising the shielding people, but you were advising, as almost like a separate cohort, the non-shielding individuals who lived with them, how to manage that dynamic?
It was. If the question is, was it ever considered to expand it to those who were living in the same household as well? Then no, it wasn't considered in those terms. But certainly there was consideration about actually what advice could be given to support people living in those households to live as easily as possible, given the huge undertaking. It was less of a problem at the beginning of the process of shielding because of the national response and all of us essentially being confined to our houses. But it became more evident as the response went on and as people started to enter society again. And at that point, we became aware of some of the apprehensions that existed within households about actually family members going back out into society and risking coming into contact with COVID as well.
Thank you. Those are my questions.
Thank you very much, Mr. Wagner. And lastly, I think we have Ms. Hannett. Back there to the right. By all means, so we're going to look at Ms. Hannett when she's asked the question, but she won't consider it discourtesy if you then turn to me to make sure your voice is in the microphone.
Thank you, my lady. Professor Smith, I appear on behalf of the long COVID groups, and I have a small number of questions for you on the approach to long COVID in Scotland. Starting off then, in your evidence this morning, you described long COVID services in Scotland as being ad hoc and as being dependent on the particular health board. The experience of members of the long COVID groups has been that this has meant there's been a profound difficulty for some of them in accessing treatment. So, for example, a healthcare worker member has found that in the absence of specific long COVID clinics in Scotland, she was unable to access the care that she needed and had to pay for the services required. Similarly, the expert report of Professor Breitling and Dr. Evans on long COVID says that the small number of boards that set up dedicated long COVID services were unable to meet the demands, the demand for them. In the light of all of that, do you accept that the variation in long COVID services within Scotland meant that very many patients had difficulty in accessing suitable care?
Apologies for turning away from you as an answer,
No, not at all.
but yes, I do accept that many patients had problems accessing the care that we would have wanted to be able to provide them with long COVID, and more than that, I think that some of those problems are enduring and that still need to be fully addressed with greater long-term understanding of what services have the biggest impact for people who suffer long COVID, and how we configure those in a way that they're easily accessible at the right time to maintain people in employment, and that we continue to learn and research this area so that perhaps in the future there'll be different options for treatment as well.
Thank you, Professor Smith. In your evidence this morning, you also said that you were not able to assist the inquiry with whether long COVID services had improved after September 2021, as there's an absence of data. Are you able to assist the inquiry as to why there is an absence of data on the efficacy of long COVID services in Scotland?
I'm afraid I'm not, no.
And finally, third, what recommendation would you ask the inquiry to make now to ensure equitable access to long COVID health care for adults across the 4 nations, and in particular in Scotland?
One of the most important things that we can do when considering COVID is the fact that across services in the healthcare sector, we've essentially absorbed the activity that's associated with a high volume infectious disease, and that continues to be the case even to this day, is that we'll continue to see a high volume of cases as a consequence of COVID, with all the sequelae, whether that be long COVID or whatever, as a consequence of that. And we need to make sure that rather than just expecting healthcare services to, forgive the term, but consume their own smoke in terms of how they respond to that, is that sufficient additional resources are made available to make sure that we're able to provide the care that clinicians want to provide care in every circumstance.
Thank you, Professor Smith. Thank you, my lady. That's all from me.
Thank you very much, Ms Hannett. I think that completes the questions now from core participants. Thank you very much for your help, Sir Gregor. I'm sorry, as I said to your colleague yesterday, I can't give you an undertaking. I'm not going to impose upon you again. We do understand the demands we make upon you and your office when we do ask you to assist the inquiry, but I'm very grateful for your help in preparing the statement, obviously, and today. I hope it hasn't been too bad a day for you.
Thank you.
Thank you. Tomorrow at 10 o'clock, please.
All rise.